So I hope that most of the people joined by now. So I'd just like to say hello, everyone, and thank you very much for joining us today. So our webinar is it's supposed to be very multidisciplinary. And on this one, we're just going to look case for older adults with pancreatic cancer. She's female, but we'll introduce the case in a minute. So then thank you very much for all the member of our panel who agreed to give their perspective from the different disciplinary point of view. So Sandy and I will facilitate, but obviously we want to be as much as possible to be interactive this webinar. And we have got Donna, who is our nurse navigator, Carlene, who is our social specialist in social oncology, social worker, Stephanie, who is occupational therapist, and Megan, who is dietitian. As you can see, we're coming from different parts of the world, which is great because in this way we're hoping to bring different perspective around the world. And later, once we finish discussing the case, we really would like to invite all of you to ask questions, share your practice, because we want to learn as much as possible from each other. So thank you very much. And Sandy, it's on you now.
Okay, just as we get started, if you would like to type into the chat, and then we will have you raise your hand as we get into our discussion, just to sort of give everyone an opportunity. And Donna, if you can keep an eye on the chat for me,
Sure.
Yeah, because I can't see the chat on my screen sharing. Okay, let's meet. I can advance. Let's meet Mrs. Lee. She is a 75-year-old female, and she had a 10-kilogram unintended weight loss over the last 3 months with some persistent nausea. I'm sorry. I'm trying to move my screen so I can, my video, so I can see, I can read about Mrs. Lee. Her history, I'll talk as I know her a little bit. She has hypertension and non-insulin dependent diabetes. She also suffers from glaucoma. She is married, and something to complicate this story of Mrs. Lee is she's been married 55 years, and her husband suffers from early cognitive impairment, has been diagnosed with Alzheimer's, and she's the primary care partner. No alcohol, and she's a never smoker. She and her husband do have two children that are married, and they live within an hour drive. Her CAT scan in the community setting shows locally advanced pancreatic cancer. So she was referred to a cancer center. I'm sorry. All different directions. And here is her CAT scan that shows the locally advanced cancer. And you can see from two views. This is how she is presenting to the oncology team.
So I'm the nurse navigator that will take the call from her prior to her coming to the cancer center. And what I do as a nurse navigator is I basically get the information so that it will make her cancer journey much, much better. So the intake questions that I ask the patient are social. So I won't know anything about this patient, and I'll ask social wise, who is in your support system? Are you married? And if you have to take care of anybody, who do you take care of? We will go through allergies, we'll go through medications. And then part of the system is asking what their distress score is. Now, a distress score is what is making you stressed out. Is it financial? Is it social? Is it the new diagnosis? So I asked Mrs. Lee, on a scale 1 to 10, 10 being your worst, what is your distress score? And she says 8. So I want her to elaborate on this, and she tells me that she is a primary caregiver of her husband who's newly diagnosed with Alzheimer's. Um, this is a brand new diagnosis for her of pancreatic cancer, obviously, and it's very scary. And then she has children, but they're not readily available all the time. We also asked what their psychosocial needs, like spiritual, emotional concerns. I always ask, is your religion a part of your everyday life? Do you go to church? Is that going to be helpful in your cancer journey? A lot of people just are so stunned that they will not answer that question. I'll be quite honest with you. So, and with Miss Lee, she just says, yes, I pray every day. The social determinants of health, she doesn't know what this pancreatic cancer is going to do with her and how she's going to take care of her husband. So her problems and barriers, she's has a poor health literacy, because she really doesn't know. She's been primarily focused on her husband. She really doesn't have much of a support system. She lives far away from the Cancer Institute. She does her ADLs okay, and her communication skills are excellent. Those are all the things that we hit on when we navigate a patient. And then we also ask about advanced directives. Do you have them? Do you want them? And if anything of these are really pertinent, we make a consultation to the social worker. And her score of being, just our score of being 8 out of 10, I would definitely make a consultation to our social worker. Sandy, we can't hear you.
I'm sorry. And then now she's with the Cancer Center. And you can see her pathology, and it is an advanced high-grade adenocarcinoma. She does not have proficient mismatch repair. She has no variants of the DPYD. Again, when the team is collecting information regarding the pathology, it is going to help guide the treatment decision making. In many cases, she may be presented at tumor board for additional decisions, a collaborative decision making process.
Right, and then obviously you saw the diagnosis. So the next step is obviously to do our testing, and then generally this is what we include the standard testing with tumor biomarkers and genetic testing, but also geriatric assessment, crash score or CAR score. Different center use different scores, but essentially we would like to assess her toxicity, possibilities for toxicity, and chance for her to develop such. So you can see her tumor markers. Normally, genetic testing, I'm sure, in every pretty much nowadays cancer center is recommended in the patient with different cancer, but obviously in this case with confirmed pancreatic cancer. And different centers use different panel of testing, and you can see some of the biomarkers that we've done for this particular patient. As I said, this may vary the panel and what test is being done, depends of which hospital you're working with or local area, but generally I think it's well embedded in nowadays practice, this testing. You can see her hemoglobin. She has got slight low sodium, again could be different, so a part of the blood test, and you do obviously use full blood count, hematinics, then her observation, she's got slight higher blood pressure on this one, as you can see. Otherwise, she's quite small and a tiny lady, I would say. And then in terms of the scores, crash and cart scores, as I said, different center use differently, but this is also help us to define if the patient has got polychemo. Do they need to be dose reduced, and how this is going to impact their potential possibilities for side effect. So, and next slide, please.
All right, so after she's completed her first clinic visit, both of her children are present for the first one, and her husband. The APP completed a CGA, and things that have been identified, of course, the concern for her weight loss, her sleep disturbance. We're concerned about caregiver strain, her husband with early Alzheimer's, and a distress score of 8. Because of her weight loss, our dietitian is going to help us out.
Thank you, Sandy. And it looks like she's been referred nice and early as well, which is always a good sign. So this poor old lady, Mrs. Lee, has got lots going on. First of all, so pre-assessment considerations. It's great that she's attending with her family because we can engage them in the conversations. She's had a clinically significant weight loss, recent weight loss, around 18%. We want to find out what the cause of this is. Is it increased energy requirements? Is it reduced oral intake? Is it increased losses? We know that she's got persistent nausea, so is there any vomiting that's been going on? And does she have any symptoms or signs of pancreatic exocrine insufficiency or PI? Her BMI is 20, so she's kind of low, but she's still got a little bit of reserve, which is a positive. We don't have any HbA1c or any blood glucose readings. We don't have a vitamin profile. Fat-soluble vitamins are always handy to have in pancreatic cases. We do know that she's got low sodium. Quite often medical teams are super on the ball with replacements and top-ups, but I'd be querying whether with the medical team whether they want any dietary input here. It might be maybe a little bit more pleasant for Mrs. Lee to avoid another medical kind of intervention if possible. Regarding her nausea, so again, is there any pattern to this? Does she have any antiemetics prescribed? She's taking Creon already, 75,000 units with each, 3 times a day, which is the starting dose for kind of each main meal. If she's having any snacks or if she's been buying any kind of protein drinks or supplement drinks or experimenting in any which way, that very well may need optimizing. And we also need to make sure that she's taking Creon correctly as well, because there is a right and a wrong way to take that. We noted that she's on some laxatives. So I just want to confirm what her current bowel pattern, her bowels are opening like at the moment. And lots of the treatments that these patients are started on can cause diarrhea too. So it's just whether they're actually needed, whether there's something that we can do with her diet to help her bowels as well. And I note her busy social history. So how much time will Mrs. Lee consider that she has to focus on herself when she's got her children, her husband, who she cares for as well? So they're the kind of things that I'm thinking about. So in terms of our plan, as I say, it's really important that we engage the family in this discussion, but the biggest thing is going to be education regarding the importance of weight and muscle maintenance during her treatment and her body's nutritional requirements. And that just helps set a little bit of context about why we're talking about what we're talking about. Quite often.
Looks like Megan, are you unfrozen?
Maybe the connection, we'll just wait for a few minutes.
Diet pattern. This might sound really simple, but oh, sorry, can everyone hear me still okay?
Yes, we hear you good, Megan.
Yeah. Fabulous. Yes, as I say, little and often might seem really simple and really silly, but actually it supports nutritional intake, supports energy intake, mitigates against lots of the nutrition impact symptoms like taste changes, poor appetite, smell aversions, and it's diabetes friendly as well. We'll be encouraging high protein and high energy intake, including maybe fortification of her meals for that muscle maintenance. And I'd certainly be linking in with my physiotherapy colleagues as well, so they can provide some kind of activity guidance for her. Creon education and pancreatic exocrine insufficiency education is really important here. I want to promote and teach her how to self-manage with this, so things can be a bit more flexible and a bit more fluid for her. I'm going to add on an HbA1c and vitamins A, D, and E to her next blood panel. As I said, they're really handy for monitoring absorption and just establishing a baseline. But she doesn't need to come in especially for those blood tests. We can add those on to her next set. As mentioned, I'm liaising with the medical team regarding her antiemetics and her sodium, as well as the laxatives. I'll give her a bit of bowel management advice, so foods to include or avoid if she's got any chemo-related bowel changes. And then I might also talk about the use of meal services, batch cooking, and ready meals. Mrs. Lee sounds like a very busy lady, and she's going to have lots going on in the coming months. So I just want to make sure that she feels that we're dispelling any guilt that she might feel of using these products. Quite often, again, when people get a diagnosis, they feel like everything has to be 100% natural, homemade at home, and she very well may not have the energy to do all of that kind of cooking. So making sure that she feels okay to use those kind of things. And then the other thing we might need to do is some counselling for the family. Cancer doesn't just happen to the patient, it happens to the family as well, and her children and her husband. If her children have seen her, and I've seen this many times in practice, if her children have seen her stop eating and losing weight, quite often that concern can be expressed as upset or anger. And the last thing that Mrs. Lee needs is for kind of her family relationships to start falling apart. So making sure that everyone knows, can everyone see the same picture from different angles is going to be really important for her, and make sure that she's well supported through her treatment.
Megan, a question for you. What does E and D and L and O stand for? That's
eating and drinking little and often.
okay. Thank you. We all have our abbreviations we live by, don't we? Especially when we're documenting. So thank you.
We do. Sorry for the abbreviation.
Right, and then next on the line is me. So Megan already mentioned about some of her medication, but obviously as a pharmacist, then I'm going to explore further what she's dealing with. The focus will be obviously to see where we can optimize her medication from a chronic condition, where we can deprescribe, because we're fully aware that once the people start chemo, they're ending with much more medication that they actually come in. So at this stage, we already identify her problems with a slight blood pressure, but one single reading means nothing really. Then she has got nausea, potentially vomiting. She has got hyponatremia. So then we're going to look exactly to see what is her medication doing. And you can see a lovely list with her medication, statins, antihistamine, which you think what exactly is going on as well. Then she's got her IP blood pressure medications, some vitamins, and again iron tablets, which we don't know exactly if she's iron deficient, what's going on, and some laxative, as you can see. So obviously, people very often don't tell what they take, or they often tell me, I feel my husband taking this, I feel okay, they're fine, let me take the same. So luckily in our case, this lady was self-management in terms of independent with her medication, but this not always mean that they know why they take things. So after establishing what exactly she takes, The next slide is just to think about what we can do and how we intervene. We know that she's got diabetes. Having pancreatic cancer definitely doesn't help her diagnosis. Her renal function at this stage, at the beginning when we saw her, wasn't so bad, but obviously we need to think about and monitor and considering if decline renal function, then and then any liver problem as well, does she need still to be on all this medication? So this point to consider. This doesn't mean necessarily stopping, but let's say if she's got short-term prognosis to live, then you think about statin, how beneficial they're going to be in her long-term condition. Iron, as I've mentioned, does she still need? So then, as I've mentioned, we normally do hematinics at the beginning to check her folate, iron, ferritin, and so on. Maybe it doesn't need it. The same as vitamin B12. Obviously, she's deficient or she's malabsorption, then obviously we continue. And then for every one of each drug, we're establishing the indication and that she needs to be currently on them while she's in preparation of treatment. So then in terms of we always need to think about falls, which is something that is very frequent with our patient and frequently use stop and start criteria and Barrett's criteria, but also the patient, how fit they are, and obviously if they had recent falls. And blood pressure is another thing that is very important to make sure that the patient hasn't got a postural blood pressure, because again, every one single reading means nothing. Often when they're older, they don't eat and drink very well. They're probably a lot of time dehydrated, which impact their renal function, but also their glucose controls could be deviated. So again, this is just an idea what we could review, but this needs to be very much tailored to individual patient and discuss with the patient, because they need to understand why we're doing this as well, just to be as they are our partner with this treatment pathway. And next slide, please. So we establish, after doing her pre-assessment and doing geriatric assessment, her performance status is 2, and medical team decided to consent the patient for FOLFIRINOX with 25% dose reduction based on her geriatric domains and comorbidity and polypharmacy as well. So next slide, please.
So she, excuse me, she comes to the infusion center, and the infusion center is it's a wonderful setting for the patients. They have medical oncologists and advanced practitioners and certified oncologists, certified nursing oncologists who help support them. They also it is a chance to re-educate the patient and to see what their needs are. Anytime a patient comes to the infusion center, they always ask what their distress score is. If their distress score is anything above a 7, a social worker gets involved. If they feel that they need like a walker because of a high risk for falls, then they can notify a case manager so that they can get a walker in place. We've already talked about nutrition and dietary counselors. If they feel that they need a little bit more education, the infusion center can call up a nurse or a dietary personnel to come up there and give them some more education or to make an appointment. And the health and wellness counselors, there are they're fairly new and they help set goals for the future and make a change in their lifestyles if they need it. So she receives her first treatment. She's arranged to have the neighbor stay with her husband. And again, the RN infusion nurse provide additional education related to potential side effects. So they don't just hand her a paper and say, these are the side effects of the drugs. They go over the side effects with the patient and then ask her to do a teach back method so that she understands.
Okay, back to the clinic. So she's sustained 2 falls at home. And her orthostatic vital signs were obtained in the clinic setting, and they were positive. She's also starting to complain of some numbness and tingling in her upper and lower extremities that may indicate chemo-induced peripheral neuropathy. Because of her orthostasis, as Vanya talked about, an opportunity to deprescribe her ACE inhibitor. She is referred to the infusion center today to receive some isotonic fluid. And because of her symptoms and her falls, she has been referred to physical therapy and occupational therapy. All right, I'm not sure if Stephanie is on. Is she able to get away from her patients today? I can't. I see only our 5 people.
Can't see her on the
It
call.
doesn't say that she's on. I can't see
Okay.
where
No.
she's on.
I know there may be phones, but let me share a little bit that may happen in the United States, and evaluate with different instruments. Clinic may evaluate a timed up and go, a sit to stand, a functional reach are some evaluations that can be provided. If the patient does not have significant functional decline and concerned about her fall risk, a referral to the Gait and Balance Clinic that provides strategies and education around CIPN. The occupational therapist can focus on that fine motor skills and adaptive strategies with her numbness and tingling of her upper extremities. Maybe the team is considering a recommendation of assistive devices for Mrs. Lee, and then a home environmental assessment. So some of the instruments that may be used is the Centers for Disease Control has an initiative called STEADY, Stopping Elderly Accidents, Deaths, and Injury, and great resources are provided. So we may ask her to evaluate her home environment. We want to convince her that she is going to be at risk as she continues on treatment and may have some weakness, some continued hypovolemia. And then a screening for risk factors that can help identify what exactly strategies do we need to incorporate.
Carlin, are you able to see the thing yet? Carlin was having problems seeing the slides.
And she actually, her microphone wasn't working earlier, so. Carlin, can you hear us? So speak on over the phone.
So some of the things that we are concerned about, of course, is being a carer herself. We're concerned, and one of the instruments that Carlin has recommended as faculty, senior faculty for social work at University of Louisville and in her practice is the biopsychosocial, spiritual, sexual, cultural. So they've got everything, a comprehensive psychosocial assessment. And she's going to be digging deeper into Mrs. Lee's 8 out of 10. Carlin, are you on?
Can you hear me now?
Yes.
Yes,
Can
we
you
can.
hear me?
Yes.
Okay.
Yes,
I
got you good.
apologize for this. It's been one of those days. Yes. So the first thing that social workers do in the process of working with Mrs. Lee and her family is to do what's called a biopsychosocial, spiritual, sexual, cultural assessment. Could you go to the next slide for just a second? What this next slide shows is what is included in what I call the BPSSC. Now, each of these domains will not necessarily be an issue for Mrs. Lee or her family, but they're important to pay attention to. You know, so I just wanted to show you what are the domains that social workers cover. So could you go back to the other slide? So one of the things I do, as social worker does, is reassess her distress scale, her distress score, and go over the problems that were identified in the problem list to see if it's gotten, her distress has increased, decreased, how her problems are, to see if they have any new problems. Based on the assessment, social workers do a lot of referring out. So we do this extensive, in-depth assessment, which actually doesn't take that long to do if you can do it as a conversation. And then we will refer out. Chaplaincy is a really big place we refer to, or we'll suggest they go back to their spiritual leader. If there's financial issues, we refer them to the billing office. We'll talk about finding a senior center in her community where her husband may be able to go to, and then suggest the Alzheimer's Association. So I put in this link because it is global, and you can see not all countries are associated with the Alzheimer's Association, but many are. And then we have advanced care planning discussions with Mrs. Lee and her daughter. And what we're looking for is what matters most to them, their medications, their mentation, and their mobility. So we've already talked about the mobility with the PT and OT. We've talked about the medication with the pharmacist. And so what matters is where does Mrs. Lee and her family want her to die? We try to get that from the patient rather than the family, but we will include them in that conversation. Very important. We'll talk about what she wants at the end of her life. Does she want to be fed? Does she want to be hydrated? Does she want to be kept clean? So what are those important aspects of care that she wants to cover, she wants to have, and that are important to her? We also talk to the daughter about what matters to her. So it's a joint conversation. Then what I do offer is psychosocial support via telehealth to both Mrs. Lee and her daughter. It is likely that Mrs. Lee will say, no, I'm really busy, because we talked about that in the one of the earlier assessments. But I will also offer it to her daughter. As we all know, caregiving is an amazing burden. And then we will see if she wants any support. And then we actually are going to arrange a family conference related to specifically
Carlin, you went on mute again.
We still can't.
No,
We
I
still
can't
can't
hear
hear
you.
you.
We still can't hear you.
And this is the United States, so you can imagine, you know, some of the internet connections that we may be challenged globally.
And I think this is a very good to address in the digital era, because we're pushing so many older patients to do digital, and I'm sure that they can. However, this also needs to be considered.
And I have a question for Carlin about roles as social work. We know that we are challenged to identify psychiatrists and psychologists for our patients, and we know that there is a huge need. Are the licensed social workers for counseling, are they able to use telehealth to provide that psychosocial support, or is it something that is not available? And then what happens in the United Kingdom?
I don't think that Carlene can actually respond to us.
All right,
Because
I'm going to
she's still-
go
yeah.
to her goals of care.
Yeah.
And we provided several links. So there's one for Canada that's created from Cancer Care in Ontario. Patient priorities care is something that that I have used. There is all kinds of provider training to have those goals of care discussion. And while we try to touch base throughout her treatment journey about what matters most, and we do know that at the beginning of treatment, quantity of life is often recognized by patients. They want to live as long as possible. But as they get further along into their cancer diagnosis and it becomes advanced, then quality of life seems to be a focus. Carlin, can you join? You're muted again. So we know that that throughout the journey, as Carlin has talked to Mrs. Lee, and they've created an advance directive, and she's identified her daughter as her healthcare surrogate when the decisions need to be made if she cannot speak for herself. So they have determined that. Continuing to have conversations about Mr. Lee's progression. So we provided you with some resources and some very practical ways if you're not comfortable in having these kinds of conversations. We always want to look for, is there another clinical trial? Is that we don't not take away their hope, but we do need to know what is their goals of care. So now we're 6 months into Mrs. Lee's pancreatic cancer. And her daughter, you know, just found that she needed to move in with her parents. It was just too much on her mom. Mr. Lee is now having some bouts of agitation. As you can see that his Alzheimer's has progressed to moderate. He's wandering at night, which is making her sleep disturbances worse. Mrs. Lee is so tired, and she has no appetite. So the hospice conversation comes up, and that is helped to be facilitated by our social workers. So Carlin is involved in logistically, what does that work? How does that work? Who takes over the care? And after 10 days, within the hospice consult process, Mrs. Lee died at home, and she was surrounded by family. With her children's support, they were able to keep Mr. Lee at home until Mrs. Lee died. Then he was admitted to a dementia unit close to his children's home. All right, Vanya.
Right. So this is just some closing thoughts. Obviously, I think it's always very lovely to see also many professionals actually inputting in one patient case, and I think some centers are really lucky to have got this variety of disciplines to help our patients. But also, I'm fully aware that across the world, not all the people have got this luxury to have got different specialties to help the patient. So as you can see for this short case, how many complications can come to one older person with cancer, with family, and other things that is going on around the part of the cancer diagnosis, and how complex could be this one. So the only way I can say from closing, obviously I would like to invite all of you to say one sentence and your take home message, but for me it's definitely having input from other discipline is a very crucial thing, because none of us can deal with everything and we're not expert in everything. So having multidisciplinary approach is a very, very important, and this only can help our patients. So it's kind of you can see how much knowledge different discipline has. So this is my take home message, but obviously please share your thoughts, and then I can open for people attendees to chat as well. Sandy, do you want to?
Can you hear me now?
Done. Yes, yes.
Oh, thank goodness. I really apologize.
I've been taught well by my social worker team. So I oftentimes have to step into those conversations. So and please, we want to get a
great job.
We want a global perspective. So, if you have questions or if you want to share something, particular that is different in your setting, that we can learn, please.
There is one question in the chat.
Yeah, I can see Darren. Thank you, Darren. If you can talk, please talk. But Darren raised a very relevant question about pancreatic endocrine insufficiency, and obviously the fact that she's so complex came with her diagnosis, and he just asking about the place on metformin and sulfonylurea in her management of diabetes, and would we consider insulin sooner? And then I know, Darren, we had a chat obviously because we're in the pharmacy group on this one. It's not straight for answer, and the guidelines, I think they vary. And I think for this type of patient, you cannot take one-stop approach. So you need to follow through the patient and monitor her very closely. And I always say, if you're lucky to have got liaison with endocrinologists, I think it's a really good opportunities to involve endocrinologists in this situation. And then some of the center, they have got specialists with obviously with cancer, with affiliation in the cancer. But it's a very good question. The answer is not one way, I can say. So obviously, if other people have got better guidelines, please share. But it's also show how complex the patient can be. So anybody else want to share anything or ask or chat, put on the chat?
One of the things from her medicine list, and hello, Dr. Walsh, how are the twins? The issue I saw that jumped out at me was the sulfonylurea, and knowing that that's like at the absolute top of the list for potential inappropriate medicines. So that would be something what the primary care team, her GP would prescribe. I would think that the GP should know better than to use a sulfonylurea. And I know that with the PPIs, that's another consideration for, but with the potential GI issues that, we're going to be facing her, probably not a good time to stop the PPI, but thank you for those opportunities for deprescribing.
It's always
and of course the statin.
Yeah, exactly.
And as a navigator, this is a typical patient, whether it be pancreatic or whether it be thoracic. That they have husbands or mothers or what have you that have dementia, and they want to stay alive to treat them. And they're the ones that unfortunately will pass away before anybody of dementia. So this is a typical case.
And they will push for aggressive treatment.
Yes.
Yeah. Can I ask one more thing about, or say one more thing, is that in the conversation with the social work, one of the things I would always ask is, tell me what you understand about your disease.
Mm-hmm.
Has anyone talked to you about your prognosis, to see if they actually heard what everyone had said to them, and that they could teach back, basically, to see that they understand and that the family understands. So there's more chance of it ending the way, her dying the way and where she wanted to die.
I think every country is different, but I think in the UK we just start doing much more advanced care planning as early as possible in that pathway. So then again, all this conversation is to start as early as possible in pathway. At least this patient feel hurt, and then shared decision making. I think it's more powerful when you start this conversation as early as possible. So then, I don't know, it will be interesting to hear what other people saying from other places and just share their practice. Really should be really interesting. So I'm just going back to the chat.
Yeah, we
to
have a team member joining us from Mexico with 4 social services in the hospital. Carlin, do you want to just speak to the distress and how, you know, Dr. Jacobson just made a very, very simple instrument to help the team dig down into what's bothering the patient?
So what is often used by many cancer centers across the world is the distress thermometer and the problem checklist. If you can learn to, if physicians and nurses can learn to ask the questions, which is, in the past 7 days, can you tell me how distressed you've been? And then there's a list of problems, and you only ask about problems that you can refer out and work on and help. If you don't have social work, then you don't want to ask them questions that a social work that you don't have someone that can provide the service. That's really important. And another thing is just start the visit with, how are you doing? You will learn a lot from just that question.
And
Okay.
engaging the nursing team or the unlicensed personnel, you know, in some of those discussions, and make notes for the provider. So then when the visit starts, the provider has some, you know, jumping off points to begin conversations. And I know that our medical assistants that do vital signs and collect other information begin that conversation at the first time. So
Yeah,
the provider,
they do that a lot where they have the medical assistant when they're having the conversation. So tell me about your distress. One of the questions in the US they're supposed to ask is, have you had any thoughts of ending your life? When I went through my cancer treatment, I was asked, you don't want to kill yourself, do you? Not a good question to ask.
No.
Because no one is going to say yes. Again, you need to have services, resources to help to send the person to, refer the person to, if they do say yes, they're thinking about ending their life.
And there's a very good talking about emotions. Laura asked a very good question. How do we protect our own emotional health when we work with such a sad cases? And this is obviously compassionate fatigue is actually quite important, and I don't think that we pay very much attention. So is there anything locally in your center that you do with the healthcare professionals? Anyone?
I personally take walks. If I have a stressful patient, I will just, in order for me to decompress, I will take a little walk around the facility and everything. But other than that, no. Or we talk about it to other nurse navigators, saying, this is this is what's happening and everything. And then we all chime in and help each other emotionally.
Barry has a question, and Vanya, we have a question about toxicity and treatment choice for you after Barry shares. Hi, Barry.
Barry, unmute yourself, please. There you go.
Okay, thank you. Yeah, thank you so much. Actually, I'm so touched that you presenting in this way, like so many people was involved to presenting about this case, and it's also very meaningful. Basically, I have like a few questions. So one question is concerning about this patient. So I see this, you really have the chemotherapy, right? So, and then after this circle, so what was the response, for example? I see you described the patient was complaining, but what was the response of the tumor somehow? Or
So
because
reality with this type of cancer, I think, and this may address what Vanya is going to talk about, is because quantity of life was important, trying to modify the dose adjust. We wanted to use the strongest, best choice at first during first line treatment. And, of course, they may repeat scans, after some treatment to see if there's a response, but the response was very, very minimal. Vanya, do you want to talk about the treatment?
I think it's also this is what is I'm looking to Rafael put very good comment. I totally agree, because the other option really for this patient was gem Capox, which is absolutely, I think, is better tolerated in this patient for whatever reason. They decided to go with, for just because they wanted probably to be more aggressive treatment, and hoping that will help the patient. But I agree with most of the elderly patients, especially they have got complication. We would choose probably oxyplatin and another regimen with capecitabine, another actually not gemcitabine and capecitabine, because you want to essentially make sure that you don't do harm to the patient and the patient will benefit. So I agree, this is a very heavy regimen and it's not for everyone. And if you have got very, very frail patient, you probably wouldn't go with that. The only problem obviously with the pancreatic cancer is it's whatever you do, I mean, the prognosis is short, unfortunately, but during the journey of the treatment, you need to always consider impacting the quality of life, because they might not live longer, but their quality of life will be very impacted from the side effects. So I agree with your comments as well.
Another
Yeah,
question, Barry?
yeah, because somehow, of course, we know the gemcitabine FOLFIRINOX or for other cancers, so but we somehow also realize that the dose, right? So how to optimize the best dose. So this is the reason that we also try to develop project combine AI, for the for the dose prediction, for example, in particularly for the combination therapy. And also, I feel that today you mentioned this special case because the patient was already suffering from this severe pancreatic cancer, but she also have to take care of the husband with the dementia, right? So I feel that somehow this is always the case, like woman was always the major caregiver. And also you mentioned about the health literature was poor. And yeah, basically, of course, I'm very, how to say, touched by this case, but I would also want to say, how could SIAC, right? How could this consortium can do something in the future about these cases? Because I think it's not common, right? So with this situation, and in the end, and when I see this 6 months follow-up, so the patient, Miss Lee, passed away, right? But husband was still alive somehow. But I feel that concerning about the purity, right? For sure, actually, Miss Lee should be consider herself to be the first purity, but in reality, it was so hard. So what can we do in the future, for example, to support this woman and yeah, to give more valuable support concerning about this case.
I think you're very right. And I think one of the things is taken at, again, as a take-home message, involve more discipline. If you have got in the local center, people have got access to different discipline. I think this is because You cannot extend life, you know, especially with cases like that very much, but what you could do, improve the quality of lives and the family as well. So reassure patient that she is well supported, her husband is well supported, family well supported. And for this reason, you really need different discipline to be involved, and not only in the tertiary center or the hospital, but their community as well. So then I think this is raise awareness. One discipline can do everything. So it's really multidisciplinary approach is something that it's very important, I would just say, to be.
Yeah, because I'm just thinking the opposite, you know. So, for example, if the man, right, cancer patient somehow, which I'm also presenting a case from China, let's say, you know, then all the family were supporting with very no doubt, but with this female case that she, as her as a patient, also have to be the care of the role of the caretaker for another one in the family. So yeah, therefore I also noticed about the stressful score or something like that, right? So but basically, I really think it's really nice that you're presenting this case, and I also learn a lot. And I also really like the way that it's such an interdisciplinary presenting and discussion. Yeah, thank you so much.
Thank you, Barry. We have a question about autonomic neuropathy. It's much more peripheral with the medication. So in her postural hypotension, we would certainly look, you know, has she had any vomiting? You know, is she drinking enough? You know, her appetite was very poor. Has she had any vomiting? Has she been running a fever? Other things to make her hypovolemic. So, you know, in that case, that was the reason of her postural hypotension, of course, exacerbated by being on an ACE inhibitor, you know, for her diabetes. So that was the first thing to stop. I think that we are getting close to time, and thank you all for joining us and being patient with all of our challenges. You will receive a survey because we'd like to know more about how we can share our best practices, you know, across across the world and learn from each other. And please take a look at those links. If you are looking for instruments, go to the SIOG website under the Comprehensive Geriatric Assessment. You'll find lots of instruments that can be used to evaluate the domains of the CGA, such as the polypharmacy, the ADLs. Please look. SIOG has a tremendous amount of resources that that all of the experts in our organization have put together. And Darren has shared that the AHA, yes, has excellent information on managing orthostatic hypotension. Also, if you go to the CDC website, the study has information around medications that can exacerbate fall risk that are very good in that setting, and talk about orthostatic hypotension also.
Sure. Thank you very much to all of you.